Hi everybody, we're going to talk about community-acquired pneumonia. Community-acquired pneumonia, or CAP, is a very common problem affecting about 1% of the population each year. It is one of the most common reasons people seek medical attention. Why don't we talk about a person with community-acquired pneumonia? Here is our first patient of the day. We can see him in clinic. We're in clinic now to see our patient. He doesn't look like he's doing very well. He appears pale, weak, diaphoretic, and tachypnic. Let's see what we know about this guy. Okay, this guy's a 55-year-old with a 3-day history of cough, fever, and chills. His temperature is 38.5, he has a pulse of 101, a respiratory rate of 18, and a blood pressure of 134/68. His oxygen saturation is good at 97%. It looks like he's otherwise healthy. He has no allergies, takes no medications on a regular basis, and has no active medical problems. We also know that he has no significant contact with the healthcare system. He has not been recently hospitalized, he is not a hemodialysis patient, and has not attended wound clinic or any other risk factors for multi-drug resistant infections. Okay, what else do we need to know? So our patient has no sick contacts, he has no significant occupational exposures, he has no recent travel, and does not smoke, use alcohol, or take any drugs. With all this information, it looks like our patient doesn't have any risk factors for unusual or difficult to treat infections. While this guy goes and takes a seat on the exam table, it's time to think of the differential diagnosis for the reason this patient is here with cough and fever. It's important to consider a broad differential diagnosis at this time. You don't want to miss anything that's potentially life-threatening or may require significantly different treatment. The differential diagnosis should include pneumonia from a variety of causes such as aspiration, bacteria, viruses, and fungi, acute bronchitis, a COPD exacerbation, congestive heart failure with pulmonary edema, lung cancer, and an acute pulmonary embolus. With those problems in mind, it's now time to move on to the physical examination. It's really important to carefully observe your patient. You're looking for signs and symptoms of respiratory distress, altered mental status, tremor, diaphoresis, or other problems that may be apparent just on observation. Take the time to confirm critical vital signs. These are vital signs that may influence your differential diagnosis and affect the management of your patient. So for our patient, which we're considering a potentially life-threatening infection, you want to recheck the patient's pulse, blood pressure, respiratory rate, and temperature. The patient's head, eyes, ears, nose, and throat examination is unremarkable. His mental status examination shows that he's alert, awake, and oriented to person, place, time, and situation. Auscultation of this patient's heart reveals a regular rate and rhythm with no murmurs, gallops, or rubs. Auscultation of the lungs reveal crackles in the left lower lung field, no dullness to percussion, no agophony, or signs of a pleural effusion. Now that you've completed your physical examination, it's time to reevaluate the data that you've collected from the history and the exam and determine how that influences your differential diagnosis. The history and physical examination is very suggestive of community-acquired pneumonia as the diagnosis. Additional testing will be needed to confirm this diagnosis and to reduce the probability of other items in your differential. It's time to order some diagnostic tests. We can order a CBC, a basic metabolic panel, and a chest x-ray. You could consider a rapid influenza test, and you could also consider sputum and blood cultures. In the outpatient setting, most physicians do not order blood and sputum cultures because these results can take several days to be reported. However, for someone who appears to be sick enough to be admitted to the hospital, it is reasonable to order these tests. While we're waiting for test results, we can talk some more about community-acquired pneumonia. Lab tests on our patient reveal a white blood cell count of 19,000 with a left shift, a creatinine of 1, and a BUN of 14. The remainder of his laboratory values are unremarkable. The information obtained with these lab tests indicate that the patient likely has sepsis because of his elevated white blood cell count in the setting of fever and tachycardia. His chest X-ray shows a left lower lobe infiltrate. No masses or other lesions are detected. Diagnostic testing for your patient shows a left lower lobe infiltrate and an elevated white blood cell count. With this information, coupled with the history and physical exam findings, you'll be able to make a diagnosis. This patient's history, physical examination, and testing most supports the diagnosis of community-acquired pneumonia. Now that we have a diagnosis, it's time to move on to the management of this patient. One of the most basic questions to ask is, can this individual be managed at home, or should they be admitted to the hospital for treatment? Fortunately, there are validated tools like the CURB-65 score, which will help you make this decision. Our patient does not have confusion. He does not have a BUN greater than 19. He does not have a respiratory rate greater than 29. His systolic blood pressure is greater than 90 millimeters of mercury, and his age is less than 65 years. So he does not meet any of the CURB criteria. Studies have demonstrated that people who meet one or fewer of the CURB criteria can be safely managed as an outpatient with pneumonia. Now it's time to talk about antibiotic selection. And we need to understand the likely pathogens involved for this patient. It's important to note that a pathogen can only be identified in about 38% of people with community-acquired pneumonia. Because of this low yield, sputum and blood cultures are usually obtained only in the most seriously ill patients with community-acquired pneumonia. Treatment of community-acquired pneumonia focuses primarily on the treatment of bacterial pneumonia. Important pathogens to remember are Streptococcus pneumoniae, Mycoplasma, Legionella, and Haemophilus influenzae. Viruses such as influenza and rhinoviruses are very common causes of community-acquired pneumonia. Treatment of community-acquired pneumonia is empiric, based on epidemiology, unless culture or other testing data identifies a specific cause. Treatment for common causes of bacterial pneumonia and, when appropriate, influenza pneumonia is essential. The ideal antibiotic for this patient would be available in an oral form and would be relatively inexpensive. Evidence-based guidelines are available for the treatment of community-acquired pneumonia, and they were published by the Infectious Disease Society of America in 2007. First-line therapy is an oral beta-lactam agent and an oral macrolide. Alternative agents include doxycycline or a respiratory fluoroquinolone such as levofloxacin or moxifloxacin. The duration of therapy should be 5 to 7 days. These recommendations do not provide coverage for influenza. It's important to remember that influenza makes up about 15% of the pathogens identified in patients with community-acquired pneumonia. Because of the high prevalence of influenza pneumonia, it would be reasonable to add a neuroaminidase inhibitor such as oseltamivir. After initiating treatment, it's important to consider what can be done to reduce your patient's risk of developing another case of pneumonia. Vaccines are available to reduce the risk of influenza and Streptococcus pneumoniae pneumonia. The influenza and Streptococcus pneumoniae vaccines should be offered to anyone who is evaluated or treated for community-acquired pneumonia.